Okay, welcome to the first of our Across programme seminars. Thank you to everyone for joining us this morning here for the UK or this afternoon for those that are in Bangladesh, India, Pakistan and around the world. Thank you for joining us. I'm going to just do a brief introduction to the Across programme and introduce our speakers for today. We'll be together today for the next hour or so, time for a presentation and also hopefully some discussion as well. So for anyone who isn't aware, Across is a new NIHR funded programme that's looking to develop a feasible and acceptable, culturally and contextually adapted and affordable home-based rehabilitation called Across, which is based on the Heart Manual and the REACH HF manual developed in the UK. And it's for people with coronary heart disease or heart failure, and will be running across in Bangladesh, India and Pakistan, and looking to extend these cardiac rehabilitation interventions to take account of multimorbidity, including depression and anxiety. Across has 4 work packages. Work package 1, which is due to start very soon in the next few weeks, is looking to culturally adapt and refine the rehabilitation intervention, which I've said is based on the Heart Manual and REACH HF. And we'll be doing that through using qualitative methods, interviews and focus groups with people in each of our partner countries, with patients, with health professionals and with other key informants to work together to culturally adapt, to refine and develop the intervention. We'll have a second work package which will start around 12 months into the programme, which will be conducting an external pilot RCT to test the acceptability and feasibility of this adapted intervention in each of our countries, and it will involve 100 patients per country in India, Pakistan and Bangladesh. All being well, we'll then move into work package 3, which is a full multi-centre, multi-country randomised controlled trial, which will aim to estimate the clinical and cost effectiveness of the Across intervention. And this will involve 1,000 patients per country. A primary outcome will be a composite outcome of mortality, hospitalisation and health-related quality of life. And running alongside these 3 large work packages, we have a capacity capability building work package, which is looking to build bilateral research and cardiac rehab delivery capacity across India, Pakistan and Bangladesh. It includes a total of 9 PhDs, 3 in each of our partner countries, and many activities around capacity building for clinicians, for early career researchers. And this seminar programme will sit within this capacity building research work package, and we'll be looking to hold 3 to 4 seminars each year of the programme, which would be 5 years in total, to share both our learnings from Across, but also to invite interested and relevant partners to present their work as well, so we can really enhance each other's learning in the area of rehabilitation. So for today's presentation, I'm delighted to welcome Emma Shiel, Elizabeth Broom and Rory Myles, who've been working on a meta-synthesis of qualitative studies that aims to understand the patient experience of group interventions for the treatment of long-term conditions, including COPD, diabetes and cardiac disease for people living in South Asia. And this review is really a collaboration between the Across team and also SAN's COPD Health Team, which is a project that I lead in the UK, which is funded by NIHR Research for Patient Benefit and is looking to co-design adapted pulmonary rehabilitation for people living with COPD from South Asia in the UK. So we've combined our teams and our knowledge to run this meta-synthesis. I'm going to hand over to Emma, who's going to talk us through the aims of the review, also something about the methods of meta-synthesis and how that's been operationalised in this review, And Elizabeth and Rory are going to join her to talk about the results of the review as well. And we're very grateful to Elizabeth and Rory for voluntarily giving their time to work on this project and to develop their own research capacity as well. But I'll let everybody introduce themselves in a little bit more detail, and I'll hand over to Emma. I'll stop sharing my slides and hand over to Emma to start her presentation. We expect be about 30 minutes, the presentation, and then we hope to have some good time for discussion at the end. So if you'd like to pop any questions in the chat for any of us, for Emma, Liz, Rory, or the Across team, please do so. Or also you can raise your hand and ask a question at the end. Jamal is here. Jamal's going to keep an eye on the chat and make sure those questions are fed in to discussion at the end. Okay. So Emma, if I stop sharing, you should be able to share your screen now if you want to do that and introduce yourself.
Can you see that okay?
I can, yeah.
Yeah, great. Hi, everybody, and thank you, Amy. My name's Emma Victoria Shiel. I'm a PhD student, but also a research assistant over at the University of Manchester, and I work with Amy on the SANS COPD Health Project. And as she said, we've been working in collaboration with Across to do this project as well, but with also Elizabeth Broom and Rory Myles. I just want to give you a couple of seconds just to introduce yourselves as well, because I don't want to kind of botch that for you. So go ahead, Elizabeth.
Hello, good afternoon or good morning, wherever you are. I'm Elizabeth Broom, so I currently work for NHS Pennine and I work in mental health services for low intensity CBT. And I also am currently a MPhil PhD student from the Wrexham University. And I'll pass over to Rory.
Hi, I'm Rory Myles. I am a senior psychological wellbeing practitioner in Rochdale in the UK. Similar to Elizabeth, I work in low intensity psychological services.
Cheers. So what I'll do is I'll just talk about the rationale first, about how we kind of came about this collaboration. So obviously SANS COPD is all about COPD, and the reason why we look at COPD is because unfortunately it's associated with at least 5% of the deaths globally, and of the 11% of people around the world who have COPD, we actually have 4.5% of them within the UK. So the UK is quite a hotspot for COPD. Now, even though COPD is very serious, we do have something called pulmonary rehabilitation, which I'm sure you all know quite well because it's quite similar to cardiac rehabilitation. And what we know about this is that it's the gold standard for COPD. So when I say gold standard, it's the best thing apart from inhalers and other medications that we can do for people with COPD to maintain their lung function and have the best quality of life that they can. However, while we know it's completely effective and we don't need to do any more work on that, we know that it's not really accessible, but we're not really sure why. So SANS COPD looks particularly at the gap between the gap with South Asian people, because when we look at the statistics, for example, we see that a lot of British people are in there, other ethnic minorities, but South Asian people we see very few of, and we don't really know why they're underrepresented in that. We have some idea, but we really wanted to have a proper look into that. When we look at the prevalence around the world, obviously the UK is very dark on there. So the darker orange something is, the more COPD prevalence. The UK is very dark. As I said, we've got 4.5% of the 11% of people living with COPD that are diagnosed. And then America is also quite high up there as well. But when we look at South Asia, we also know that quite a lot of people have COPD there. So then there's this question of, well, if a lot of people from South Asia have COPD, why are we not seeing them in pulmonary rehabilitation? So that's where the SANS COPD project came in, and that's got multiple work packages similar to the Across project. So work package 1 is a systematic review, and it's very similar and kind of lays the rationale for the metasynthesis that I'll talk about in a moment with Rory and Liz. So I'll just go very briefly over the findings from this just to kind of set the scene. So as Amy said with the title before, we're looking at group interventions for long-term conditions. So myself and Amy, working in the SANS project, did this for South Asian people living outside of South Asia. So it wasn't just the UK, it was anyone living anywhere in the world but South Asia, because we wanted to see if, living outside South Asia had any impact on that. And we could use that transferable information to the UK. We also decided to look at group interventions and long-term conditions rather than just COPD. And the reason we did this is because the evidence base is just really small. Unfortunately, when we were doing this review, we actually couldn't find any qualitative papers on COPD itself. So we actually had to do a lot of learning from the cardiac rehab stuff, the diabetes things, and that's what we've been looking at. So COPD, diabetes, and cardiovascular disease, because we felt that all of these had group interventions that were similar to pulmonary rehabilitation. So if we can work out why people are or are not going to them, we could also use that learning for pulmonary rehabilitation and also for the diabetes education and the cardiac rehab. So this is just a kind of snippet of the findings. This is what we call the line of argument synthesis, and I won't go too much into what that is because Rory will explain it later on. But basically, it's a diagram format of findings. So from what we found of all them studies, I think we found 17 studies overall for people outside of South Asia. We found that these kind of 4 themes summarise how we can support people to engage in group interventions like cardiac rehab and so on. So we know that safe space and professional relationship is at the core of it. We know that people need to feel safe in order to take part in something like this. For people with COPD, they get very breathless, same with cardiovascular disease and diabetes. They all have physical kind of health complications that can stop someone engaging in something or can make them nervous about engaging in something. So having that safe space was really important, and that was facilitated by having the right qualifications, having the right equipment like oxygen machines and so on, blood pressure machines, and also personalised care, so making sure that everything was unique and tailored for each patient. We also know communication is really key. There's some things like literacy skills that we found were really low, so it was really important that doctors explain things properly. We found that a lot of the explanations were rushed, or they just were very complex, using language that people didn't understand. And the use of interpreters was quite frustrating because it was either that the interpreters were used and they weren't effective because they might not have the right dialect, for example, or it might be that the children, the patient's children, are doing the interpreting, and because of that, the patient themselves are completely excluded from the care because it's just a conversation between the child and the doctor, and then unfortunately the patient is left out of that and may not actually hear everything from that conversation as well. We also found that the venue is really important. There was a few papers in there that took cardiac rehab into temples, gurdwaras, things like that. They were really effective in bringing people in because they felt comfortable and happy there, and it was a familiar environment. There were things like motivation, which were belonging in faith. So, for example, people were praying a lot, and while they thought that was important for their health, obviously cardiac rehab, pulmonary rehab are obviously very important as well. But some people prioritised religion over the medication and felt, if I'm doing that, I don't need to go there. And then there's also this kind of acceptance that came from faith, which on one hand was really good that people were accepting that they had said diagnosis, but sometimes this also held people back from coming to get help because they accepted that that was a part of their life, and that's why we've got fatalism there, because people said, God gave me this and this is my challenge to overcome on my own. So a lot of people didn't go for extra help, they didn't go to the hospital, didn't go to appointments and so on. And then finally, there was the cultural aspects. So representation, living outside of South Asia, there weren't that many South Asian people in the programs or kind of within the kind of service itself. The people who led it might be British, for example, and people didn't feel represented in them services. There was also a problem with transport. This was found a lot in England. A lot of the women couldn't get in the taxis because they were on their own and they didn't want to be in the taxi with a male, or sometimes people were just inappropriate with the way that they drove or beeping horns and things like that. It just wasn't appropriate or nice to be around. There's also this cultural duty, we've named it as, which is basically the men are providers in the family naturally, and the women tend to look after the children and clean the house and so on. So they found that when it came to healthcare, they didn't always have time, or other things were prioritised and so on. And then finally, cultural adaptations. And this was things like the need for separate sex sessions. So a session for the men, a session for the women. There was also one where they had a cardiac rehab in the style of a dance and things like that. So it was more culturally acceptable and interesting and so on. So we found some really great findings from this, but the ones I've underlined there, cultural adaptations, explanations, interpreters, and so on, we got thinking, is this just exclusive to outside South Asia? If we have all of these interventions in South Asia, surely they don't have problems with interpreters or explanations because it might be in their own languages and so on. Surely they'll already have cultural adaptations, but we really didn't know. So that's why we ended up with the review that we're showing today, which is looking really at, from that question of the differences between South Asian people who reside in and outside South Asia. That led us to understanding the patient experience of group interventions for the treatment of long-term conditions for people living in South Asia. So really the same review, but kind of flipped the other way. So instead of outside of South Asia, we chose to do inside South Asia. So what we did was, because we'd already completed that review prior, the one for outside of South Asia, we were able to use our methods already and reuse them and redo them for this project. So it was really nice to reuse that and also know that it worked already and just kind of build on what we'd already done. So this is just a very quick example of our syntax. I don't need to go too into it. This is just to show you that we looked at COPD, cardiovascular disease and diabetes, group interventions among South Asia, and also they were qualitative as well. So I won't go too much into this. I'll just kind of give you a brief overview of what the metasynthesis is. When I was looking into the metasynthesis initially, it's quite a muddy kind of methodology and it's not always that easy to understand. Once you get it, it's very easy, but I think understanding it can be quite difficult and there's not too much support out there to understand it. So hopefully this presentation will also teach you a little bit about how to use this methodology as well. So this method is by Noblet and Hare in 1988. And while it's systematic in nature, so when I say systematic, I mean step by step, it's actually very interpretive, so it's very flexible. So while it's prescriptive and it says you must do this, this, and this, there's also kind of some room to have a bit of individuality on it and have your own spin on that as well. But the main aim of a metasynthesis is to basically look out what's already out there, look at the evidence, bring it all together and bring your new insight on that. So really you want to bring everything together that already exists and then identify your own key themes and concepts and theories that provide a new explanation for that phenomenon, which in this case is South Asian people with long-term conditions in group interventions. So when I say it's prescriptive and systematic and there's lots of steps, these are the steps. So there's 7 steps altogether. And what you do is you follow these one by one all the way through to 7. But it is an iterative process. So when I say that, it's, yes, you go through 1 to 7, but you might repeat or go back on a few steps, particularly step 3, which is reading the studies. Now we do this because it brings you as close to the data as possible, because it's interpretive, and it means that we kind of cast in our own judgments about what's out there and our own versions of what's already out there. We need to be really careful we don't stray too far from the fact. So when we go back and we read that over and over again, we make sure that we're grounding everything we say within the data. So you might see you go step 1, step 2, step 3, step 4, back to step 3, back to step 4, step 4, then step 5, back to step 3, step 6, back to step 3, and so on. So it can go back and forth like that, and you can do it as many times as you feel comfortable to. So we'll go through each step and what that includes, and then also tell you about what we did. So we're kind of learning about the methodology as well as what we have done as well. So in step 1, getting started, this is where we identify the research area or gap. Obviously, we did that through our previous review, so we already had that sorted. This is where you then also formulate your question, which we asked, what is the experience of barriers and facilitators to access, engagement and completion of group interventions for South Asian people living inside South Asia with long-term conditions? And again, long-term conditions meaning diabetes, cardiovascular disease and COPD. We then established our aim in this stage as well, and that was to synthesise existing evidence from qualitative studies that explore barriers and facilitators to access, engagement and completion of group interventions for South Asian people with long-term conditions. Going into the next step. So the first one's all about setting the scene, what you want to do. The next step is, okay, what's actually relevant? And this is where you build that strategy that I touched on earlier, which is this kind of huge table here. What keywords are you going to look at? What are you actually going to search? So what we did, we used a spider tool, which Liz will talk about in a moment, which is basically an acronym for different areas that you look at, and I'll let Liz talk through that. And in there, you decide what you want to actually pick out of the research. And then you also, like I said, decide on your strategy, so all them keywords, but also where you want to search. We search databases like Medline, PsycInfo, CNAL, Central, Embase, and Applied Social Sciences Index and Abstracts. Really, you can search where you want, but we wanted to kind of cast the net far and wide because we knew from our previous review that there wasn't much out there. So I'll let Liz go on to the next slide and tell you about what we were including and also what we decided on in the end.
Thank you very much. So with the study having a qualitative focus, we very much had specific ideas of what needs to be included. So if we think of the sample size, we looked at adults, so that was anyone aged 18 and over, and with kind of primary diagnoses of diabetes, cardiovascular disease, or chronic obstructive pulmonary disease within South Asia. So within that, there were people that will have other health conditions, both physical and mental health. And as long as the kind of the primary was the diabetes, the cardiovascular, or the COPD, then they were able to continue with kind of the study. They were appropriate for the criteria. The specific interest was kind of the views, the experiences, but also the attitudes and kind of the opinions about group treatments for these long-term conditions. So this might have been within the community, it might have been within primary care or secondary care. So with it being qualitative, the research methods included semi-structured interviews. There were focus groups, but also observational methods included. And within that, the synthesis of data, the primary focus when reviewing was the views, experiences, the opinions, but also the attitudes around the group intervention specifically. And within that, we wanted to identify the barriers and the facilitators to both accessing group interventions, the engagement, but also completing them. So we found that kind of when some people started, they didn't necessarily finish. So within this, multiple articles were found. So one of the things that we noticed, there was a big gap that was found with regards to kind of the countries. So whilst there were papers from Bangladesh, India, Sri Lanka, and Nepal, what we didn't find, because of the exclusion criteria and because of the qualitative specifics, we didn't find any papers from Pakistan. And while the Across study did look at kind of cardiovascular disease and it did look at cardiac rehab, because of our criteria, we did not find any qualitative papers that fit our criteria, but also looked at cardiovascular disease and or cardiac rehab. But what we did find from these studies that did look at diabetes or looked at COPD, we found that the learning from this is transferable. And what you'll notice is that from the kind of the group treatments, there is specifics around education, but also about kind of the type of intervention and the rehab. So it very much focused on pulmonary, but also some yoga. And if I pass back to Emma now.
Cheers, thank you, Liz. So yeah, so they're the 5 that we found. So it was a significantly smaller amount than our previous review. So while we thought there weren't many things in our previous review, there was even kind of less of an evidence base when we look inside South Asia. So there absolutely is so much rationale to work within this area. Moving on to the next step, we've got reading the studies. And as I said, this is something that you'll do kind of continuously throughout the whole methodology. So this is where you read and extract all that data, which Liz just spoke about then. So we extracted the author information, country, population, health condition, type of group treatment, the way that they collected the data. So was it an interview? Was it a focus group? So on how they analysed it. Was it thematic analysis? Was it interpretive phenomenological analysis? All these different ways. And what their key question and their findings were. And just kind of for future reference as well and kind of advice, it's always good to pop it in a table like this just because it's really easy to come back to and really easy to come back and quickly read. We also kind of alongside this as well had a separate table which included first and second order constructs. And this is where this review methodology really becomes the metasynthesis. You won't see this in, other systematic reviews. This is specific to the metasynthesis. And the first and second order constructs are basically fancy terminology. The first order constructs are the raw quotes from the participants. So when you have a journal paper and there's maybe box 1 that has all of these quotes in there, they are first order constructs, the raw participant's voice. The second order constructs are the author's voice, so nothing to do with us, it's the person who wrote that paper. And that's what we want to take out. And I usually put this in a table just to make it easier. So we'll have the first order constructs, them quotes, and then we'll have the second order constructs about them quotes. So what did the author say about them? How did they interpret that? Naturally, when you're reading this, you'll probably think, oh, well, I would have said this, or I thought that, or the author might have missed that. That is our interpretation. So that doesn't belong in this section. So if you're like me and you can't help yourself, write it down, because this is a really good bracketing method to keep yourself out of this stage so you don't kind of contaminate that stage. And also it can help you down the line when you do them potential themes later on, and I'll talk about what they are later on. But yeah, this is just for the participant quotes and the author's thoughts about them. So then we move on to the next stage, and as I've said, I've already wrote there read and reread. So again, we're already repeating stage 3 and do that throughout. At this stage, when you're reading and reading and reading, writing your notes and things like that, you'll start to notice some comparisons or some differences between different concepts. Some people agree with each other, some people disagree, and so on. You might also start to build some themes, some overarching storylines, and find out some explanations for a lot of phenomena. So you want to note this all down, and then at some point when you feel confident to, you'll realise that you'll be able to cluster these into sets, and also another word for initial themes. So when we were looking at all of this data, we found that data kind of naturally fell into these sets of having a lack of disease knowledge, ability to participate, the value of treatment, the venue, stigma or reluctance to disclose, family, finance, trust in healthcare professionals, and communication. So these are our kind of preliminary sets. And then at this stage as well, you also want to decide what kind of translation you want to do, another metasynthesis specific method, which is basically the choice between a reciprocal or a refutational translation. A reciprocal translation is very much like improv. It agrees with everything. It says yes and. So paper 1 says this, paper 2 agrees and says this, paper 3 agrees and says this, and it builds like that, kind of like a building block. The refutational translation is the opposite, so it kind of disagrees with everything. So paper 1 said this, paper 2 disagreed because they think this, paper 3 disagreed with that because they think this. But naturally, sometimes papers agree and disagree. So you can actually do kind of amalgamation of the two. So we chose to do that because of what our data said. We had a lot of some that agreed, some that disagreed. So we did a mix of the both, and I'll go into how that looks like in a little while. And at this point, you also want to conduct quality appraisal, for which we use the Joanna Briggs Institute Critical Checklist for Qualitative Research. Now, in metasynthesis, you can have loads of data, and because it's qualitative, there is lots of data to work with regardless. While we had 5 studies in this, there's actually a huge amount of data because it's all so many quotes. So if you do have lots and lots of studies, it can be a good idea to remove the ones that are kind of poor quality. But we decided not to, because I think if we took out anything from the 5, we'd actually lose quality in our overall review. And also we were lucky enough to actually use very good high quality articles anyway that didn't need excluding. So I'll just go into them sets that I was talking about, lack of disease knowledge and such, and show you how we actually came up with them. So when we were looking over the data, we kind of put in each box there, we worked one by one, paper 1, paper 2, paper 3, and we came up with all the concepts which were explored in each one. So paper 1 had quite a lot of concepts, paper 2 had a few less, and then paper 3 was probably the least amount of data in there, and so on. So there, every single individual paper, what they included. We then had another box next to it. Okay, what was repeating throughout these other papers? So we can find now from looking at this table, we know that lack of disease knowledge was in paper 1, paper 3, and paper 4. It's very small, I can barely read it. But yeah, we can see what was present in each one and what wasn't. So we know which papers fall under which topic and so on. I also had this grey box here, which we just put something that we found interesting but wasn't, comparative or wasn't said across other papers, just in case we wanted to touch on that as well. So that's how we came up with these sets. It's basically a long time of reading, rereading, and seeing what's common between all of the papers. So then into the next step, translating the studies into one another. This is where we take them sets from before, so that lack of disease knowledge, all them different topics, and the papers that are included within each of them. We take them and we rank them papers from highest to lowest. So the best quality papers go first, and then the lowest quality papers go last. And what we do is we compare them into one another within each set. So the papers that were included within lack of disease knowledge, for example, in fact, I'll show you, I think I've got it on the next slide. Yeah, so the papers included in lack of disease knowledge were papers 1 and 3. The papers included in ability to participate were 1, 2, 3, and 5. And papers included in value of treatment were all 5 of them. This is just a snippet, it's not all of the sets, it's just to show you how we did it. And what we do is, because we used a mix of reciprocal and refutational translation, we have paper 1 says this, and paper 3 agrees or disagrees, and this is why. Paper 1 says this, paper 2, and so on. And that's how you work through it. And then you have basically a really good starter for your write-up, because essentially you already have this very well-analysed set of data already written up. And I just want to say as well, these kind of little analysis kind of paragraphs that you do at the start of the third order constructs. So before, when I said the first order constructs are the raw participant quotes, the second order constructs are what that author says about them, the third is ours, and it's okay at this point to bring your own in, and this is where the metasynthesis kind of really becomes its own. And as I kept saying before, make sure you keep going back, make sure you keep reading, going back to all them tables that you did, because it just makes sure that every interpretation you make on this data is grounded within the data as well. So now I'll just pass it over to Rory to explain line of argument synthesis and our findings from that as well.
Thanks, Emma. Yes, so the line of argument synthesis, it's essentially creating a new original interpretation that goes beyond the translation of the data. So highlighting both similarities and differences in the data. It aims to represent the review findings and further develop those third order constructs of those themes, categories that we came up with. So here is the diagram of the third order constructs. So hopefully you can see those, the titles of those categories there, but I'll go through each one in turn. So the first really important category that was that could have been a barrier or a facilitator was knowledge. So obviously you've probably heard the quote, knowledge is power, and what we find is that people who seem to have good knowledge about interventions and a good disease knowledge seem to be more likely to participate. So there's just a quote here. This is from a patient. No one knows what causes blood sugar to increase or decrease. There's nothing you can do to control the disease. So one may assume that this person might not want to get involved in all the rigmarole of rehab if they don't think that there's anything that they can do to control it. Yeah, so another huge one here was trust and communication. So that was a big part of that was trust in healthcare providers. So I can see a quote here that someone's saying that I knew that physical movement made my symptoms worse, but my doctor told me that exercise would help me. I followed his suggestion, but I was always afraid. So I think what we're seeing here is how important it can be for to trust our doctor. We might have certain preconceptions or fears about what an intervention what negative consequences an intervention may have, but a doctor can be a really important person in allaying those fears or giving us confidence. Another element of trust was trust in the intervention. So someone here saying, I can now climb the stairs up to the second floor, which I never thought I could. So again, it's showing that people who trust in the intervention are going to be more likely to do it. And I think it's really important to say that these themes are all very highly interlinked, aren't they? That we look at trust in the intervention, but that really plays into knowledge, doesn't it? And that's kind of why we've designed the visual diagram in this way to show the links between them. Another really important point is the desire to participate here. So someone's I mean, it seems obvious, but it's a really important point that if someone doesn't want to do an intervention, they aren't going to do it. So someone's said here, I don't take any medications, I work on the farm, so that in itself, it's a lots of exercise and physical activity. And I think what they were getting at there is I already do all this, so I don't want to do any more. So yeah, actually wanting to engage is essential. Moving on to the other side of the diagram now, we've got culture, which was a huge factor. So we can see that someone and cultural beliefs that people have. So someone said most of our diseases occur due to our own sins. So I guess if we have this cultural belief, then that may make us, certain cultural beliefs may make us less likely to want to engage in these health interventions. Very highly linked to that is stigma. The quote here is, I'm worried that other people will think that I've done something wrong in my previous life to get the disease. So that might be a real kind of barrier to engagement if we feel that we're going to be judged negatively. And again, a really kind of key one was practical barriers, practical considerations to take. So someone had said it was 75 kilometers from the pulmonary rehabilitation centre. So it needs to be a 3 to 4 hour journey to travel due to kind of broken transport. So if we assume that it's going to be very hard for someone to attend pulmonary rehab or other interventions, then that's going to make it less likely to happen, and vice versa. That if it's easy to attend, then they may be more likely to attend. Liz or Emma, do you want to kind of jump in and add any more about that?
Yeah, I think there's one thing that I want to include as well, just within the stigma. Obviously, There's this cultural stigma. There was also something that stuck out quite a lot, which we didn't see in the other review, which is about finance. A lot of people were saying, well, I've got bills to pay, so they come first. There's prioritization of different needs. And there's also the fact that they're a lot very reliant on family members. And because of that, family members might have to pay for them. So there's a lot of kind of aggression and anger and frustration around why should I have to pay for your illness and so on. So yeah, as Rory said, lots of things that interlink, and that's why we laid it out this way, because they all kind of fit together in different ways and have many different links. Liz, do you have anything else to add?
I think you both covered it. I was very much thinking of the same thought that, they're very much interlinked, and with that practical barriers, things that seemingly are not practical actually feed into that practical, like you said, finances or being far away.
Yeah. So we'll just move on to kind of the conclusions, because I'm concerned about the time kind of running up. But kind of in the question section, we'll come back and ask you about this diagram and see if you've got anything that you can bring to it or any different amendments I think would be really helpful. But basically, after the line of argument synthesis, we came to the write-up. We use the emerged guidelines to do that, and we only completed writing this the other day. So this is really kind of key takeaways from the entire thing, what we can tell you. So merging all of them different kind of steps of metasynthesis together, the translations, the line of argument synthesis, followed by an actual kind of narrative expression of that. These are kind of the key points. So I don't want to go over too much there because Rory's already covered a lot of that. Just the fact that knowledge and its self-efficacy there in gold, we found that they were kind of the most overarching things and kind of the most important things to consider when looking at whether somebody will engage or not. So do they have the knowledge to participate, because do they know what it is? Do they know it's helpful? And do they actually have that motivation to help themselves as well? Do they have the tools to be able to actually think, okay, I need to get help, I need to participate in something, or I need to make lifestyle changes? But one thing I really want to kind of highlight here, and the reason I want to highlight is because it's such a good link to across, is this need for home-based interventions. So a lot of what we were talking about there, the stigma around people being ill and how that might look like, having a home-based intervention in the privacy of their own home was, feasible and a really good idea for them. The people who, were 75 kilometres away from the intervention, again, having it in the home was an amazing option for them. And the people who, for example, might have practical barriers, like they're actually just too ill to leave the house sometimes, or COPD flares up, or they might be too breathless to travel that far, or so on. Home-based, again, a very, very good option. But I do want to kind of highlight this, and I think it's really important that we see this, is actually there was a lot of cultural considerations that may apply and reasons why this actually might not be effective for some people as well. So when I was looking at the discussion and I was writing this up, I found that there was lots of things to say that home-based interventions are just as good as the ones held in the centre. So there's a huge evidence base to have them, and there's real good reason to have them, and it seems like it'd be really effective in dissolving a lot of these barriers that we've found within this review. But there were actually some problems, particularly for females. So females in particular, when they're in the home trying to do a home-based intervention, that is technically really where they do a lot of their work, where they're doing the house chores, where they're feeding the children, they're looking after the family home. And it's not really easy to get that protected time when you're within the house. So while home-based might be an incredible option, for women, it actually might be more beneficial to have that allotted time away from the household to make sure that that time for their health is protected and done so properly. And then also something we found in the wider literature in that discussion section as well was people need to have high self-efficacy to take part in home interventions, because they need to have that get up and go, they need to have that motivation, because it's at home, a little bit kind of how working from home doesn't always work for people. People don't always have that same motivation as they do in the office, or like they don't have the same motivation as they do in the intervention as they do at the home. So it's really important that we listen to these kind of points and consider them when delivering home-based to make sure that it really is as good as the centre-based ones. So that's everything from us, unless Rory, Liz, you want to add anything in?
Not at this time, thank you.
I think we've covered it all, yeah.
No. So I guess I'll open up the floor for some questions, and also if anyone wants to comment on the line of argument synthesis, we'd absolutely take your advice on board as well.
Thank you so much, Emma, Rory and Liz, for presenting the findings and for that kind of masterclass in metasynthesis as well, really. Hopefully it's given everyone a really good insight into the method and how you can operationalise that method to produce qualitative reviews. Fantastic, thank you. So we'll open up to questions. Jamal, I think you've been keeping an eye on the chat if you want to come in with any questions from the chat.
Hi, Emma. Hi. Yes, this is a nice eye-opening presentation. Thank you so much. I have got one questions from Professor Rod Taylor. So I think, please, Rod.
Thanks very much, Jamal and Amy, and thanks to our speakers for your presentation today. Really interesting and a very insightful analysis. So I put a couple of comments in the chat, so I'll try and keep it brief, but I think, certainly the volume of literature, no surprise. I think we really lack qualitative literature more widely in the rehab setting, particularly in unmet need groups such as South Asians. So I think your small volumes maybe not unexpected. I guess I'm particularly interested because, as you said at the very end of the presentation, we're going to be focusing on home-based programs. And certainly when we discuss qualitatively access to rehab with our UK patients, they seem very supportive of that. Were there any particular barriers? I mean, as you say, obviously being 75 kilometres away from the hospital setting is a real problem to getting rehab. So it would seem intuitively a home-based programme would be better. But is there anything in this particular population that you think might be an issue around even a home-based programme with these particular individuals? I guess I was particularly struck by some of the cultural barriers, things like stigma around, in a previous life, I maybe shouldn't have had heart disease because it indicates I did something wrong. I mean, that's a very difficult thing to try and get over in terms of getting people on board. So I'll shut up and just see if are there any specific things around the home-based access in this population you think we could learn from?
Yeah, absolutely. I think informed from this review, I think home-based is absolutely the most effective way to deliver this in South Asia. I think given most of the people were complaining about living in such rural areas, people didn't even have access to train stations or any kind of form of vehicle or anything like that. There were some people who said, well, I did have a train station by my house, but the tracks are all broken down, so it's actually not in use anymore. So people literally had no way to get to any intervention. So home-based is absolutely the option for them people. But yeah, as I was saying at the end, the worries are, can they actually have that protected time or will it be disruptive? Because it's all well and good saying, yes, we'll have this at the home, but if actually they're then not able to complete it still, then what do we do? So it might be that, yes, home-based is the right option, but maybe we need some kind of specialised kind of focus on, for example, females and bringing them into the centre, and how can we do that? Obviously, resources very limited. Sorry, go ahead, Amy.
Thanks, Emma. Yeah, I just was going to add to that chimes with some stakeholder consultation that I was involved in Pakistan several years ago around the intervention for depression, where we met with lady health workers and talked about the best way to implement low intensity interventions for depression and how we could include part of that intervention would include work at home for people. And it was very clear that there needed to be some negotiations around time, particularly for women to take part in that intervention, whether that be going out to an intervention or engaging in something at home. But there needed to be some discussion, support, advice for women around that and how to negotiate that.
Yeah, I completely agree. And as well, something that I wrote in the review yesterday was, if we can't do anything, for example, fixing transport, bringing women to the centre to have that allotted time, is it more so an argument of education? Can we educate the family better to know that this is protected time, this is special healthcare time, and so on? Rory, do you want to go on?
I don't think there was there wasn't really a lot of mention of it within the research that we did, but I think there's a lot of opportunities for technology as well to really assist with home-based interventions. One thing that I've been very involved in is online therapy for depression and anxiety, and one thing that we found is that there was a lot of digital poverty within Rochdale, and there was a lot of people who were just not confident using computers. So we had a kind of interim option where people could come into the centre, like a centre together, and actually learn to use the technology together before they then move to that home-based stage. So it's a kind of, I mean, even if you could, even if there was, you could consider an additional stage of helping people get confident with the interventions before they started using them at home. That could be an option as well.
I think another question has come from Maria. The question is in chat box. There is also fear factor of exercising. Did you find anything related to it?
Yeah, absolutely. Yeah, we actually found quite a lot of data on that, and I think we labelled it at first in our sets as lack of disease knowledge because, like I said before, a lot of people with COPD, breathlessness is a part of that disease, and people are too scared to get breathless. But in reality, getting breathless in a funny way makes you less breathless and helps you kind of keep your lung capacity. So really, it was about increasing that knowledge and helping people to get over that mental barrier. Rory came up with something really good in the line of argument synthesis when we were putting this together, and it was knowledge versus abstract knowledge. What knowledge do we know about it, and what do we think about it? Rory, do you want to go on about that?
Yeah, well, kind of in my work in low intensity work, we could, for example, someone with COPD might, if they're that breathlessness, that they might tell themselves, "This is I'm going to die," or "This is bad for me." And as a practitioner, we can tell them, "No, you're not." Okay, that's one level of knowledge, but actually the most important level of knowledge is the experiential knowledge, rather than the abstract knowledge. It's actually trying it out and then deciding and then realizing, oh, actually I didn't die. And those two are very different things. So there's one thing to be said for us actually delivering delivering the knowledge of in an abstract way, but then we've got to move people towards actually that experiential knowledge of I tried it out and nothing bad happened, and actually maybe something good happened.
Yeah, and I think there also is the consideration as much as that is true, there might be some people who simply cannot take part. So we do actually have to accept that as well. But yeah, the fear factor was absolutely throughout a lot of the data, and a lot of the quotes were quite sad. They were talking about how I just sit on the couch because that's all I'm able to do, and things like that. Or I can't do that because if I get breathless, like Rory said, I feel like I might die, and things like that. So yeah, Maria, there was absolutely lots to do with that. So yeah, knowledge probably is the best way to kind of resolve and counter that.
Do we have any more questions or comments that people would like to make on the line of argument synthesis, the themes, or any questions people would like to ask Emma, Rory, or Liz? Jamal?
So, yeah, I have one question. It's very interesting that it's the barriers and facilitators. I think from the physician's perspective, because physicians are the very good largest part of stakeholders of this process. So, from the physician's perspective, is there any? I mean, isn't there any kind of statement that the knowledge and the practical experiences from the physician sides, they can give up the stigma or any kind of fairness to the patients? So is there any kind of things you can get from this review?
Yeah, I think you kind of said it yourself there when you said knowledge and then stigma. The knowledge kind of, with the reason why I put knowledge, culture, and desire to participate on the outside was that they kind of directly influenced absolutely everything. Because we could make the perfect intervention, and it might be that someone simply does not want to participate. So these were kind of the most important factors we felt. But when you said knowledge and stigma, yeah, we found that was really key because a lot of these cannot be overcome with knowledge. So desire to participate, can we convince someone to take part by increasing their knowledge and the value of treatment? Cultural considerations, will people think that it's a problem from a past life, but if we tell them, actually, this is why it happened, again, knowledge is resolving that. Trust and communication, again, can be built with knowledge. The more, like Rory said before, knowledge is power, people feel confident. And then the stigma and all that, again, everything can almost be eliminated with knowledge, which was really, really interesting. Go ahead, Amy.
Yeah, just to say, I agree with what you're saying there, Emma, but I think it's probably something that involves knowledge on many, many levels, like at the individual level, but also at the community level, and raising awareness in general, because it's very difficult, I suppose, to change strongly held beliefs like physical illness is down to something I've done wrong in a previous life, for example, that is a cultural belief, perhaps a community belief, that we need to think about improving knowledge and reducing stigma on many levels.
Yeah, exactly. Why I'm asking this, because in practical sessions, when I am a physiotherapist, I'm doing rehab in cardiac sector. So sometimes the cardiologists, sometimes they give some ideas to the patients that don't move, don't do exercise, anything else. So like kind of instructions. But even in the hospital settings, when we provide any kind of, try to provide the exercise programs, sometimes they feel kind of practical experience. Knowledge gap from the rehab and the clinical part of their intervention. So it's kind of the patient feels stigma. I think feels what they do actually. The physician said this, and the rehab part they are saying this, and they feel very discomfort situation. So how could we overcome this? This is the actually fact.
Thanks, Jamal. I think I just saw somebody else put their hand up.
Yeah, Chaudhary Meshkat.
Yeah, I'm a cardiologist from Bangladesh. I just had a comment about the culture, the influence of culture on this home-based care. Bangladesh especially is having a transition. More and more people are now being involved in their work. I find that people who are working, not very intellectual work, but day-to-day physical work, they're more motivated. They're more involved in all this home care and other things. In contrast to the people who live in the city and are relatively privileged, this is one of the important transitions that I observe among our people, because Bangladesh is grossly an underprivileged country. But in the people who are underprivileged but who are engaged in their day-to-day life for earning their bread are more motivated than in contrast to the people who are privileged. This is one of the interesting observations that I really had to mention, meaning that beside culture, the occupation that you are having, the struggle for life you are having also has got some influence in getting all this home-based care. I'm observing people living in a remote area with minimum education, but since they're working for their life, they're well motivated and taking care of their people. That is what I have to say.
Thank you so much. Emma, did you want to make any comment on that?
Yeah, I thought it was really interesting because I agree. I think like the socio-economic aspects are absolutely so important. I mean, I look at everything from a holistic lens. So I'm always looking at what aspects of people's lives influence what. And I would absolutely agree. I think it's interesting that, you say a lot of these like physical workers, for example, are more on top of their health. And I can see why that might be, because obviously they need their body to do their job. If someone's poorly and not very well, someone who's a farmer won't be able to farm. They're not going to get money and be able to live and so on. But I have found it interesting because obviously Rory read out that quote earlier that we actually found the opposite in a sense. There were people who were saying, well, I do all this physical work already, so why do I need to do more? And I think it goes back to what Rod said a few minutes ago in the text about how there's also the education side, so people don't always realise there's more to it than just the physical aspects as well.
Thanks, Emma. Really interesting. Thank you. And I think that brings us to the hour now. So I think we'll have to leave it there. But please do feel free to email us if you have any other thoughts, comments or questions. And thanks so much to Emma, Elizabeth and Rory for presenting the review today, and for everyone for their helpful comments and discussion points as well. We hope our next seminar will be in September. So we'll be sending details of that seminar out to you as soon as we have them, and we look forward to seeing many of you then. Thanks so much.
Thank you very much.
Thank you.